Good morning, everyone, and happy Friday. Welcome to today's Changing the Way We Work Community of Practice for Ontario Family Physicians. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto and delighted to be able to bring you this series in partnership with the Ontario College of Family Physicians. And I'm going to turn things over now to our president-elect, Dr. Eric Wong, to introduce the session.
Thank you. Good morning. Welcome, everybody. And I'm sitting in today for our president, Dr. Joe Verghese. Okay, next slide. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Back to you.
Thanks, Eric. And I'm calling in from Toronto, the lands traditionally used by the Wendat, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Mississaugas of the Credit. And in terms of my reflection today, a few sessions ago, I was talking about a book called 52 Ways to Reconcile, in which David Robertson outlines 52 things that we could do in order to walk with Indigenous people on the path to healing. And a couple of those caught my eye. One was about learning more about the 60s scoop. Another was about watching an Indigenous television show. And a third one was about enjoying Indigenous humor. So I thought I would just share with you a couple of shows with this cold weather, dark nights, and lots of snow. It's been a great time for hibernating in the evenings and watching television. So one of these shows, Little Bird, is you may be familiar with it. It's from 2023. It's a mini series that's actually about the 60s scoop and follows the story of a First Nations woman who's adopted during that period. The second show you'll see there on the right-hand side is Bear's Lair. This is, if you're familiar with Dragon's Den, this is sort of a similar format but friendlier. And really interesting. It showcases Indigenous entrepreneurs and as they compete for some funding. And then the last one there is North of North. This one I've actually really been getting a kick out of. It's a comedy, but also has some messages. And I love the fact that the creators, who are Stacey Glock McDonald and Alethea Arnakak Barrel, have filmed it entirely in Iqaluit, so it's actually visually very beautiful to watch. And also that they've used that opportunity to host a mentorship program in which local trainees were able to move around the different parts of the filmmaking process in order to, give them exposure to filmmaking, as this is the first major TV series to ever be filmed in the Arctic, and perhaps give them some interest in pursuing an area like that. Anyway, some things to check out. If anybody has other books or TV shows or things that they have to recommend, then please pop them in the chat. Otherwise, to the next slide, please. So just a reminder that this is part of a series, and we always have our other sessions posted, and you can see them. And also all of the content is reviewed by our scientific planning committee in order to mitigate any potential bias. Next slide, please. If you weren't able to watch this session live and are watching it afterwards, just a reminder that if you submit self-learning program, you can earn credits for it. There's a link and a form to fill out after you watch the session. Next slide. And now on to introducing our two panelists. I'm really thrilled that we're going to have some respiratory update as well as chat about the new hypertension guidelines. So first, turn things over to Dr. Dan Warshafsky to speak to his conflicts of interest.
Yep. Hi, morning, everybody. Daniel Warshafsky. I'm one of the Associate Chief Medical Officers of Health in the Ministry of Health, and nothing to declare.
Thanks very much, Dan. And now over to Dr. Vincent Key, who we're thrilled to have joining us today to present on hypertension.
Good morning, ladies and gentlemen. Thank you for having me. So I have nothing to declare as well, too.
Great. Thanks very much. And to the next slide. And Eric?
Morning. disclosures are on the screen, none of which will impact the content of this session today.
Great, thanks. And I've already introduced myself, but in terms of any conflicts of interest, I don't think anything that is up there provides a conflict, but I receive an honoraria from the OCFP and also for some work that I do for the Foundation for Medical Practice Education. Next slide, please. So just a reminder, if you're new to this session, in terms of participating, please post all your questions in the Q&A, not in the chat. Please put them in the Q&A. And also look to see if the question that you were thinking of asking is already there, in which case please upvote it, because that way I can choose the questions that are most upvoted to ask to our speakers. And then, of course, use our chat to share your hellos, your resources, your thoughts, and generally to network with your colleagues. Next slide, please. So at this point, in terms of the rollout of the session, we'll hear from Dan and then take some questions, and then we'll be turning things over to Dr. Key, to Vince, to talk about hypertension. We plan to finish all of the main content by 9 a.m. and we'll extend afterwards if we need to, if there are lots of questions remaining. Otherwise, at this point, I'm going to turn things over to Dan.
Great. Thanks much, Eleanor. Hey, morning, everybody. So let's jump into the next slide. Just providing a quick update on where we're at with the respiratory season at this point in time. So this is the quick summary of our big three here. I won't spend a lot of time on this slide because I have more details coming up. I think the key points are we're starting to see COVID go up a little bit and slowly. We're certainly not seeing a big jump in COVID, a push for a large wave at this point in time yet. But COVID always remains very, very difficult to predict what's happening. Flu remains very low. We got through that peak and it's staying at very low levels. Maybe a tiny, tiny increase of flu B at this point. And so whether we see more significant B in the next month or so is probably anybody's guess. But a little bit of increase there, but really not a lot of flu happening right now. RSV is peaking at this point in time, and that's really the main thing that we're seeing at this point. It's looking like, and I'll show in a couple of slides coming up, that we have the pediatric peak is probably happening just about now. And our older adult is probably going to be peaking in the next few weeks. So that RSV is really what things are significant at this point in time in Ontario. So next slide. So just showing that this is the percent positivity in our testing. You can see on the bottom left here, flu has, again, bottomed out. Flu season in terms of the influenza A season is really, really done. That last little bit is, there's about 1% positivity for flu A and 1.5% positivity for flu B right now. But it's very slow going. COVID's been slowly creeping up over the last little while. So we're just about 7% positivity right now. Again, you can see that it's a very different trend from the last 2 years on here. So the blue being last year's COVID and the gray being the year before. Not really matching up. So it remains a surprise for us every single year we're seeing for COVID. Anyone's guess as to whether we're going to have more of an increase, but in either case, it's very, very slow going. RSV, again, that's what the main story is. It looks like we're peaking right now, as you can see. Lower peak in terms of positivity than previous years, and as you'll see coming up, lower hospitalizations as well. So next slide, please. Just quickly showing our emergency department numbers here. So this is from our ACEs system. Black line is this season that we're having right now, and the dotted lines are historical averages that we have. You can see we're very, very low at this point in time. So that peak that we had in the black before due to flu was a little bit earlier and higher than some previous seasons, but we're very, very low at this time. We're seeing maybe a little bit of increase, particularly over 65 population right now, which again is really the RSV peak that seems to be coming. So next slide, please. This is our current hospitalization numbers. COVID, even with that percent positivity creeping up, it's not really doing much right now in terms of hospitalization, which again is really good news. I know Dr. McGeer spoke a few weeks ago about how we're not seeing the same level of severity from COVID as we had in previous seasons over and over, and I think that's what we're seeing here in these trends. It's staying fairly stable right now, around 300 patients a day in the hospital as the average, so much lower than we've seen in previous seasons at this point in time. But it looks like with the percent positivity going up, that'll probably stick through a little bit into the spring. And probably means that our spring booster program is going to be a little bit more important this season than maybe it has been in some previous seasons. Flu, again, you can see we had that quick spike. It's come down. We have very, very few hospitalizations at this point in time. And RSV, again, is what we're seeing peak at this point in time. So we're just about 200 patients total. That's between both pediatric and adult. It's mostly adult at this point in time, about 150 of them are adult, and the remainder are pediatric. So pediatric hospitalizations are remaining very, very low. Next slide, please. Just quickly in terms of how we did for immunization this year. So flu, we did bangbusters. It was really, really great. So we've had this is end of December numbers, so it's gone up a little bit since then, but mostly hopefully everybody got their flu vaccines by end of December. We saw about 850,000 doses administered through primary care, about 2 million through the pharmacy sector, which is about 200,000 doses more combined than we saw in last season. And we had that big bump in December from all the great work that everybody was doing to promote it before the actual wave came. So that was fantastic. COVID, it was a very slow start this year. It's caught up a little bit from where we were. Really what we're seeing is stable immunization rates, a little bit lower than last year. In the younger age groups, really didn't see much change. That's because they were so low to start with predominantly. So you can see anyone from basically 44 and younger, the rates are under 5% in terms of coverage. What we're really hoping for, again, is that older population, 65 plus, but particularly 75 and older. And we saw some drops, about 5% in that 65 to 75 population, and nearly 10% in the older 75 plus population, where it's okay coverage, 42.6% in that group, but it's probably something we'd like to see a little bit higher for next year. And again, we got a little lucky this year with the very mild COVID season so far. Next slide, please. So this is now just going to show for RSV a little more detail because this is what's peaking currently. You can see, so hospitalization for 25, 26 this year is the solid purple line. Obviously, overall, way better than we saw last year where we had that really, really big spike for older adults, way better than the 22, 23 season where we had that really big pediatric spike. Much, much delayed in terms of the start of the season. So that had nothing to do with anything we did. It was a very, very late RSV season. And it looks like it's probably overall going to be similar in terms of the peak to that 23-24 season. If we look at percent positivity, it is similar, a little bit lower, but probably going to be similar to those last couple seasons as well. So next slide. And this is where it gets a little more interesting, is looking at the splits between the pediatric and the older adult percent positivity. So you can see in most years we really had that pediatric peak coming earlier in terms of positivity than we saw for older adults. It's the kids getting it, passing it to their parents and grandparents afterwards. This year, it's been very, very different. You can see the huge delay. We're not seeing that classic spike that we saw in the other years. Like, it's a very, very long and slow rise to that pediatric population up top. Looks to be coming down now. So again, it looks like we've peaked in terms of our pediatric positivity. But you can see it's pretty overlapping with the older adult positivity for probably just timing of when things were coming was right around, the holiday season where people were together. So it was very, very quick transition. But you can see a much steeper incline for that older adult population in terms of percent positivity. And if we go to the next slide, please. And this is where the really interesting stuff comes in. And sorry, it's a busy slide with the charts and the graphs and everything, but I'll go through it. First, you can see on the top line, so that's our pediatric hospitalization. We have bottomed out this year, which is exactly what we're hoping to see from the advent of our immunization programs. So, 22, 23 again was that huge spike, that really bad season. 23, 24 is a more average RSV season. 24, 25 in the dotted purple was where we first introduced nirsevimab. And again, that's where we had that huge older adult RSV peak. So hard to say at that time how much was really from nirsevimab or not, but we knew there was some benefit. If you look at this year, we have very, very little. This is a flat line almost for our pediatric hospitalization for RSV, which again, 2 seasons now is really indicating that the immunization program we have is making a difference. Our uptake, and sorry, I didn't have a slide on this. I don't have the very latest data available from Born, but it's about 75% coverage that we're seeing for nirsevimab within newborns within hospital, and about another 5% that we're seeing in terms of Abrysvo coverage for parents. So that's really, really good in terms of almost 80% coverage and protection for infants from RSV. And that's clearly playing out, I think, at this point in time in the numbers we're seeing. So if we look at the peak for that infant population, in 2022, we had over 200 infants in the hospital at the peak. This year, which it looks like we've peaked already and are starting to come down for those pediatric, it was just 42. So huge difference. The other graph in the green one is the total over the entirety of the season. And you can see looking last few years. So in 23, 24, we had 7,400 infants that were in hospital over the entirety of the RSV season. So far this year, just 2,600. So we're really seeing a huge impact from that immunization. The bottom slide is the bottom graph, I should say, is our older adults. So you can see, again, we're not seeing a big peak. It's kind of this long, slow peak. Maybe it looks like it's going up a little bit more now as the percent positivity peaks, but still way better than last year. Again, we do have the expanded immunization program for 75 and older. Impossible to say at this point how much is that program really versus just a better season than last year, which was exceptionally bad. But if we're looking at a few things, so the peak last year was almost 280 patients in hospital. At this point, if we look at the numbers today, which is our current peak, it's just 157. So that's a big difference. And so far, only 7,000 patients total in hospital from RSV for older adults compared to over 12,000 last year. So again, is this just a better season for the older adults? Probably that's a significant component of it. Are we getting some benefit from our immunization programs? I hope we're seeing that as well. So that is it from me, Eleanor. Happy to turn it back to questions.
Amazing. Thanks so much, Dan, for taking us through the data. And I mean, isn't it lovely that numbers are low?
Yeah.
So it's good that you have a short report today. I'm
Yes.
pleased to hear that. We do have a few questions. So I'm going to start with the first one, which actually isn't related to the respiratory viruses, but it's the one with the most upvotes. So we'll start with that. It's now that PHO has stopped supplying swabs, what's the best way to source swabs, such as for HSV?
Yeah, that's a great question. So I think so. Supply Ontario still has swabs, I believe, that are available. So through that portal, they have the swabs. I can't say for sure. I'm not sure if they have like the actual tubes in the medium to put the swabs in after you've done the sample. So something I can double check on. Otherwise, I think it's looking for, reaching out to the labs to see, Life Labs, Dynacare, et cetera, other places who have swabs available for testing that's done. But I can double check Eleanor on what supplies Supply Ontario does have available and get back to everybody.
Okay, great. That would be fantastic. Question from Alan. What percentage of total people got the flu vaccine? And also interested in the percentage over 65, if you happen to know those stats.
Yeah, we don't have the splits yet this early in the season. It's a great question. So again, we had a better total so far, just about 3 million doses administered that we know between primary care and pharmacy. So that's really good. That's higher than we had last year by a few 100,000. Generally, the splits that we see are about 65 to 70% coverage in the older adult population over 65 and 25 to 30% in the general population outside of that. We'll know that, probably in another month or two to see exactly what that split was. It's just waiting on the data to come in, but it's probably going to be very similar to those standard numbers that we get year over year.
Okay, good to know. And then actually just a question around the COVID vaccine. Harry was wondering what proportion of family physicians have taken the leap to give COVID vaccination and document in Panorama, hoping the One ID sign up is not a deterrent.
Yeah, that's a great question. It's pretty early because we haven't actually officially switched over yet. It's not until I want to say April where the COVAX is actually decommissioned. So I don't know how many people are actually going to sign up through the One ID to start administering because it's a little bit early. What we can say is that, the numbers of people who are doing through COVAX were extremely low as physicians at this point in time, like triple digits, not quadruple digits at this point that we were still seeing. I'm hoping that the One ID makes things easier for people and we see a bit of a better uptake, but it's probably a little bit early for us to tell for sure what that's going to be like. Right now, it's still getting the information out, teaching people, how we can use that One ID system. It is hopefully going to be easier for people than the multiple other logins that COVAX has. So I'm hopeful we get a bit of a bump with that.
Yeah, and actually maybe that's something we can think about for a future community of practice. I admit to being fully out of the loop in terms of the switch to Panorama, so and maybe others are as well. So that might be something we can bring forward as a learning option. Okay, on to some other questions. So regarding RSV, the vaccination. So for those over 75 who received RSV vaccine in the last few years, when should they receive booster shots?
Yeah, it's a great question, and we still don't know exactly when boosters should be given at this point because we're watching the protection in the data. We have to date, good confidence in 4 years of protection from Arexvy. Abrysvo we've shown for 3 years, but the trends are very similar in terms of what we're seeing for effectiveness in that real world data. So there's no reason to think that it's not going to last as long as the Arexvy does. At this point, NACI hasn't made a specific recommendation on when boosters should be. So is it going to be at that 5 year mark? Maybe I can't say for sure yet. Probably, there is a slow decline over those years in effectiveness. So maybe in that range. But at this point, if anybody's received it since it started, we're not seeing that they need another booster yet because the protection is still holding up really well for the first 4 years at least.
Okay, great to know. And then a question here, any discussion in the MOH about lowering the age of coverage for the RSV vaccine to 65?
Yeah, it's a great question. I think what we can say at this point is we're still looking at this season at exactly how things went and what the uptake was. It's not completely done. The RSV vaccine we're still having administering because it has that multi-protection. It's going to continue to be administered through the spring as the COVID program will be. Overall, uptake was lower, I think, than we expected in that older population, and I think probably it was the overlap of timing and newly with COVID and flu and everything all at the same time with RSV. It was just a lot for people to do. And frankly, we heard that fridge space was at a premium because of that. And certainly that contributed as well. So, from what we know so far, there's been maybe about 500,000 people that received it, maybe a little bit less, or that's doses at least that went out to primary care providers. So I don't know how many of those are actually given yet, which is lower than the full 75 plus population. If we're seeing those similar trends and good data as we saw in other jurisdictions, then we may go down to 65. NACI is still most strongly recommending it for 75 plus, but we are waiting as well if they have any updates after this season to suggest that 65 plus is a benefit as well. So can't say for sure what's going to happen for next year. We're still trying to get through this one a little bit.
Yeah. Thanks for that. Just another question regarding vaccines. So when will a spring COVID shots be available?
Yeah, so the spring program should be starting in April. That's what we did the last couple of years. It's looking like we're going to do it the same. So April 1st through to end of June will be that spring program. And again, RSV can continue. And sorry, Natalie just reminded me in the chat that we will be having a survey on the RSV program coming out to primary care providers shortly. I don't remember exactly when. But that will, if people can reply to that survey, so PHO has put something together, and I think OCFP OMA will be sending things out. That would give us a lot of information on the program and really help to Natalie saying early March in the chat. So early March, and that'll give us a lot of information on how we can expand that program in the future. So thanks, Natalie.
Great. Yeah, we can look out for that. A question here about swabs again. So why can't we get in our office swabs for like flu, RSV, and COVID testing? This person mentions, I think you answered this before, but they don't remember the reason. So perhaps you
Yeah,
can cover it again.
So we don't, and we haven't for many years provided community-based testing for just general respiratory disease, flu, COVID, RSV, just because of the huge volume. Like it's not even possible to do all those tests, frankly, if we were to have every community provider submitting those swabs in. So the general respiratory testing, there's multiplex or just flu, COVID is for hospitals, long-term care homes, other congregate settings, high-risk populations. If you're a primary care provider in the community, there's the Sentinel Physician Program that you can join, and through that program, you have access to testing for the broad range of respiratory seasons, and that's to help us with our surveillance in terms of what we're actually seeing and spread across the province for it. But otherwise, those swabs aren't available for just general respiratory testing in the community because again, the volume's too high and the value of them in community is limited outside of that Sentinel program.
Great, thanks for clarifying that. Question from Hal. So he's mentioning there's an article in the news about Kai data showing the really big numbers of pneumonia cases last year. Could this be COVID since we don't swab or rapid test anyone anymore? And could the new test be a chest X-ray?
It's a good question. So, we still test everyone who's in hospital. Right? Like, so everyone in hospital with respiratory symptoms is getting COVID, flu, RSV, the full multiplex respiratory swabs. And so what we didn't see for at least the hospitalized pneumonia patients was that pneumonia was related to COVID infection. Does that mean we can definitely extrapolate to all the community patients? I mean, I can't do that for sure, of course. But it seems unlikely that we would just have from COVID, low-grade walking pneumonia in the community as a common clinical presentation, but none of it coming into the hospitals or the ICUs. So again, it's not possible, but it seems less likely that it's COVID and more likely that it's due to other things that we saw. So, last year at least, unless I'm getting my years mixed up, we had that really big mycoplasma season, which was a huge jump in pneumonias, particularly walk pneumonias in community. So we see that variation just yearly between the bacterial causes and other ones that we have for pneumonia. So all I can say is that right now, in the hospital data, we aren't seeing the pneumonias are caused by COVID. Yes, of course, we do sometimes see people who have COVID and then bacterial superinfection, additional pneumonias on top of it, but not a significant change in proportions from previous seasons that we think a big chunk of new pneumonias are COVID specifically.
Great. Thanks for going over that with us. And then there's a couple questions just around RSV, specifically. So if somebody was hospitalized with confirmed RSV, should they still receive the vaccine the next season?
Oh, yes, for sure. So we know that natural infection from RSV wanes, within 6 to 12 months, right? Like that's why people can get it year over year. So we're getting much better protection from the vaccine. So the NACI does have some timelines that they're suggested around this. So if you just had confirmed RSV infection, yeah, it's probably not worth getting it for this season. For that 6 months, it doesn't make sense, but absolutely would still recommend it for the next season for anyone 75 and older for sure. If they're 65 with comorbidities in that high risk group, absolutely.
Right. And I think this was a question, I don't remember whether it was in the chat or not, or in the Q&A, but is there any benefit to waiting until the fall to give the RSV vaccine, just to sort of, because you're looking at this 4 years, or would you just say give it whenever?
Yeah, I mean, because of the multi-protection, I think the first thing I would say is give it whenever, just for the opportunity. We don't want to miss it. We don't want to have, yes, we're booked for the fall, but then I get sick earlier and I don't come in and I don't get it. So take the opportunities when you can with the multi-protection. Would it line up the best and give you the, exact coverage and get you through more seasons in the fall? Sure, you might get that one extra season out of it, but probably better off just giving it whenever you can. And then when boosters are recommended, we give the booster and get you ongoing protection with it.
Yeah. And just to clarify, someone had thought RSV was just given in long-term care. It's obviously can be given in any clinic as well.
Yes, yeah. So this year it was expanded to anyone over 75, community long-term care, wherever. So everyone over 75 coverage in Ontario, and then still the same high-risk populations. That does include, long-term care retirement residents, but it's people on dialysis, transplant, Indigenous patients. I don't remember the whole list now. It's like 6 or 7 items, but I'm sure someone can pop the link in the chat to where it is, and you can go through. But it is pretty broad for people who are higher risk.
Great. I'm going to ask you one last question, then we'll turn things over to Vince. And then there's a couple of questions still in the Q&A, which perhaps you can take a peek at. So just around, if you can't test for COVID in the community, could you just go over how patients who qualify get access to Paxlovid?
Yeah, so we do still have rapid antigen testing available. And that is available specifically for this purpose. So if your community, so both through pharmacy or primary care, those rapid antigen tests are available through, again, that Supply Ontario portal. So you can have them available to be doing it. For high risk individuals, that's really the method of choice for the quick turnaround through rapid antigen testing, if it can be done. There were pharmacies, a small number that were still participating in the COVID PCR testing program, but it's like couple dozen, I think, left in the province. So it's not really a good way to do it anymore for community and dwelling individuals. So really, though, if patients are eligible for testing, you can still do the PCR swab in community. It's really just for people who aren't eligible. But the rapid antigen test is probably the best bet. You can have them available in your office. You can give the patients a few to take home with them, have 2 or 3 if they're high risk and going to potentially be sick and needing Paxlovid.
Great. Thanks very much, Dan. So I'll leave you to maybe look at those last few questions in the Q&A, and we'll turn things over now to Vince.
Great. Just before I begin, I just want to quickly correct my declaration of conflict. I have done sponsored talks and ad boards for various companies, mainly in the realm of diabetic nephropathy and chronic kidney disease. So in terms of today's talk, there's definitely no conflict of interest. These are my own slides and my own opinion on the guidelines. So with that, thank you very much for inviting me again, and happy to do a quick update on the new guidelines that just came out last year. Some of you may have had a chance to see them as well too. So next slide. So just as a background, we all know how common hypertension is in Canada and in the world. And we know it's even more prevalent among people who do have risk factors for cardiovascular disease, namely the diabetics, people who are overweight, hypercholesterol, smoking, alcohol use patients. What we've noticed in the last 5 to 10 years, interestingly, is that our control rates in Canada, which had previously been very good compared to the world control, have actually been declining. We actually still do pretty good among people who have coexisting risk factors. So among our diabetics, our vascular patients, we actually do control blood pressure quite reasonably. But in general, our rates have declined. And what we've also known is that the awareness of hypertension among our patient population is suboptimal as well. And so with the lower control and lower awareness, that leaves excess cardiovascular risk. Next slide. So some of the reasons that were speculated, maybe there's been various kind of iterations on what is the optimal BP target. Maybe that's made things a bit confusing. Although our guidelines have been highly comprehensive through SHEP, they can sometimes be a little dense and maybe overly complex. We probably all have in our minds that very, very big flow chart in terms of diagnosing hypertension or not. And that can sometimes be a little bit complex. Implementation strategies for updates in the guidelines may not have been as adequate and robust. And then one of the big things has been suboptimal engagement of frontline practitioners, including yourselves, in implementing the new guidelines. Next slide. So last year and maybe 2024 have been very big years for hypertension. So the European guidelines came out in 2024, followed shortly by the American guidelines for hypertension. And then ours also came out last year around May, June 2025. And so there's a lot of chatter about hypertension and how to manage and diagnose over the last year or so. What's very interesting about our Canadian guidelines this time around is there was a purposeful and dedicated creation of a primary care specific guideline. And that's what's been published first. There is still a comprehensive guideline that's in the works right now and hopefully coming out sometime this year. So we'll await that. But today I do want to talk about the primary care guidelines because I do think it is a very novel and interesting guideline. Next slide. So one of the goals of these updated guidelines was to, number one, ensure we have very standardized diagnostic approach to hypertension. And one of the big things, and they did do a lot of stakeholder engagements, including patient partners and other primary care leaders, on how can we make the diagnostic process and the treatment process easier and more pragmatic for all of us. And so one of the big things was simplification. And you'll see that later as I talk about the new guidelines. The big emphasis, of course, with all of this is that we want to improve control. We want to improve diagnosis and awareness at the primary care level. You're all well aware that our patients really depend on you for much of the management of hypertension. I think 90% of all hypertensives is managed at the primary care level. So you are indeed the leaders in managing hypertension. And so to make a process easier to adapt and implement is paramount for controlling this condition. And then finally is ensuring that we do include very good aggressive lifestyle modification. And you'll see where that plays in these new guidelines shortly. All right, next slide. So we're going to do like a nighttime show, like 10 pointers in hopefully 10 minutes. So here are my takeaway messages. And originally I said top 10 here, but I shouldn't say top 10 because the guidelines actually have top 9, so I didn't want to take away from their top 9. So I'm just calling my section the takeaway messages from the guidelines. So let's go. Point number 1. No more manual blood pressure readings. We should all be now using validated automated blood pressure cuffs in our office for measuring and diagnosing high blood pressure. This system is the one we use. This is the same system we use from that was used in the Sprint guidelines, which is the Omron professional series. And so definitely something we should do. Next slide. Point number 2. If we're using automated blood pressure cuffs, our patients should also be using automated blood pressure cuffs. And now, not all blood pressure cuffs are made equal. So I've left below the link, and you could find this on Hypertension Canada for all the validated blood pressure cuffs. These two brands, most of their models are indeed validated, so Omron and Bios. I should also declare I have no conflicts of interest from any of these blood pressure cuff companies. I wish I did. I never thought about it way back then, but I don't have anything to declare from them. So point number 3. Now, here is a big change. So instead of memorizing, I think there were 3 or 4 different numbers for diagnosing hypertension depending on risk, they have made it very simple. Just remember 130/80. If you are above this number, you are clinically defined as hypertension. This is actually slightly lower than previous guidelines, and part of this has to do with ongoing understanding of cardiovascular risk that actually starts quite shortly after systolics of 120, in fact. And so we're using a lower target to try and capture people better. Yes, you might think, oh, this might increase the number of people who are going to get treated. And theoretically, yes, that might be the case, but they've also changed the way their treatment algorithm works. And so really, we're probably going to see in the long term about 1 to maybe 2% increase in the number of people actually being treated for hypertension because of this lower definition. The emphasis, of course, from the stakeholder engagement is this will help with earlier detection and implementation of management. And this is, again, both non-pharmacologic and pharmacologic intervention. And as usual, once you diagnose, always remember everybody needs to be screening for cardiovascular risk and end organ damage. Next slide. Point number 4. Once you've measured a blood pressure that's above that threshold, we highly and strongly recommend that they all be confirmed in the outpatient setting, and that is either through an automated blood pressure monitor or through home blood pressure monitor. That remains the same compared to the last iterations of the guidelines. Next. Okay, here's the fun part. When do we start treatment? So the number here to remember now is 140/90. Again, making it easier. For some patients, this is actually a little bit lower starting point for some people. But 140/90 is the second number for you all to remember for when we should start therapy. Now, what if the patient is diagnosed with hypertension at 130 and above, but they're below 140? Do we ignore them or not? But no, and that's not the case, and I'm sure you don't. These are the people we want to monitor. Now, if you have a consistent reading above 130 but below 140, you then look at cardiovascular risk. If you are high cardiovascular risk and you have any one of these conditions here, then you are indicated for pharmacotherapy. If, however, you aren't in this high cardiovascular risk, but you have been diagnosed with clinical hypertension, then you need to be, number 1, monitored, and number 2, you should be instituting aggressive lifestyle modification. And then you review these patients every 3 to 6 months to see whether things have changed from a risk perspective and whether their blood pressure has now exceeded the 140/90 and needs pharmacotherapy. Next. Point number 6. The third number for you to remember now is the target. So the target blood pressure for the bulk and majority of patients is now less than systolic 130. This is largely based on the SPRINT trial data, which you are all familiar with, where we compared aggressive targeting of blood pressure to even less than 120. Now, why didn't we adopt 120 as the target? Well, it is, number one, a very intense target blood pressure to achieve. And when you actually look at the study, for people who were actually included in the 120 group, not everybody got down to that tight target. And we also know that blood pressure targets in trial settings are actually usually a little bit lower than real life blood pressure monitors. And we want to go with real life kind of data. And so the 130 became the target. This was also through patient and physician stakeholder engagement, and they supported this target. And of course, the big thing is when we target very, very tight levels, there are potential harms. And so this was the middle ground between avoiding harms but maximizing benefits. So 130 systolic is the target blood pressure. Okay, next. Point number 7. Another novel idea that came out in the guidelines is when we start treatment now, the starting therapy should be a combination agent, preferably a single pill formulation. And this was based on a randomized trial. And forgive me, I actually forgot the name of the trial, but where they actually found that starting people on combination therapy up front actually led to better control, better adherence, and even more effective, actually, blood pressure lowering. What was very interesting is the long-term follow-up of patients who were started on combination therapy up front was that they actually ended up being more adherent to expanded regimens. So more than maybe 3 pills a day, they were more adherent and had better control in the long term than people who were started on individual agents up front. One of the other big benefits of starting low-dose combination therapy is less side effects. So here are the three agents of first-line choice, and we all know the various combinations of these agents. In the past, there was a very strong recommendation to avoid maybe thiazide diuretics like hydrochlorothiazide, and to use agents like chlorthalidone and indapamide. There was a paper published in 2024 in the New England Journal that actually found that they're actually quite comparable. But the general consensus still among us hypertension specialists is that we choose longer-acting agents like chlorthalidone and indapamide if possible. The difficulty, of course, with combination therapy is that there's not too many formulations that include these agents in their combination. So it is still okay to use hydrochlorothiazide-based combination agents. And when you actually dig into the guidelines, the preferred first-line agent based on availability, cost, and effectiveness is the irbesartan hydrochlorothiazide combination. Okay. And then so that's kind of a novel idea. Next, point number 8 is once you have exploited those 3 agents, so you've started their combination agent, blood pressure is still not well controlled, you've added in whatever the third agent that hasn't been included yet is, so whether that be a diuretic or calcium channel blocker, this guideline series has now recommended a fourth agent addition, and that's spironolactone, much based on the Pathway 2 trial, which compared spironolactone, doxazosin, and bisoprolol as add-on after failure of those 3 agents. And they found spironolactone had the best efficacy in getting blood pressure down. And in fact, we in nephrology use spironolactone more often than not now for kind of more resistant BP. So that's kind of the agent of choice now. Next. And resistant hypertension I want to remind everybody, the definition is blood pressure not a target when 3 or more agents are used, and it has to include a diuretic. Remember, when you're looking at someone who you think might be resistant, always rule out potential pseudo-resistance. So make sure they're adherent. Make sure it's not because they're non-tolerant to medications and they've actually stopped their medication. Rule out white coat hypertension with outpatient investigation. And now I should have put the fourth point first, and that is always look for an interferent. So that is anything, a medication or a substance that the patient might be on that may be increasing blood pressure. And here's kind of a moderate list of some of the common things, including NSAIDs, licorice, decongestant, and oral contraceptives. And then finally, this is the group where you're going to think about secondary hypertension. And then final point. Most common secondary hypertension out there right now is endocrine-based hyperaldosteronism. It's becoming more noticed and intervened upon. And in fact, there's a recommendation that maybe what we should do is for people who you do see who are seemingly a little bit more resistant to the top 3 agents, you should maybe screen them earlier with an aldosterone-renin ratio, and preferably before you consider adding something like spironolactone. And consider at this point to refer to a local expert, especially if they have some of these other risk factors that I've mentioned above. And with that, I'd like to conclude. Next slide. Very, very prevalent disease with high complication rate, but our control and diagnostic rates have started to fall, so we need to improve this. And hence, this last year, Hypertension Canada put out a very clear and simple and comprehensive primary care guideline, with the main changes being now earlier diagnosis at 130/80, earlier treatment above 140/90, and targeting lower at systolic less than 130, start 2-drug combination up front, and the add-on agent after the first-line agents have been exploited is spironolactone. And with that, I'd like to finish my talk, and thank you very much for listening.
Great. Thanks so much, Vincent, for taking us through that and presenting the new guidelines so that we can learn from them. And quite a few questions here. There's been a battle of the upvotes here, but I'm going to start with the one that's currently at the top, which is regarding the simplification to the 130/80 and specifically around older patients. So the comment is simplification forgets the comorbidity of our older patients, and lowered levels for elderly can increase the risk of falls. And just if you could comment on that. And I'm just before you start commenting, there's a second question that was quite similar in terms of should we be adjusting treatment recommendations for older adults based on their level of frailty or life expectancy. So maybe if you could talk to that, that would be great.
Yeah, so this is always the question, and I think the guidelines really is for the majority of patients. Okay, we need to. It's a general guideline for a majority of the patients who present to you with kind of new onset hypertension, but I totally agree. This is where medicine is not just a science; it's an art, and this is where we have to take into account our patients' various factors, including their frailty. And I do practice this as well too. So right now, as the guidelines state, we should be keeping to an aggressive diagnosis target and starting treatment earlier. In people who are frail, you do want to be scaling back, and you wouldn't be faulted by maybe holding off treatment if they already have pre-existing, say, falls risk, pre-existing labile blood pressures where they might be hypotensive, sometimes posturally dropping all the time. You may have patients who might have cognitive impairment and have difficulty following through with treatment. So you don't want to run the risk of them either overdosing their medication if in fact their blood pressures are only slightly above target starts. So I don't think there's anything wrong with streamlining the guidelines for patients who have these other cofactors that we need to be careful of. And remember, these are guidelines. Okay, these are not a hard stop law. These are guidelines, and this is where we as doctors need to practice with the art as well too.
Great.
And I also mentioned one of the other things. So there had been a comment before that, oh, it was a general comment in terms of, is there concern with all elderly people? But I should mention, there are also very robust elderly people, and there were people over 80 in the sprint trial, and there were people over 80 who were targeted to down to the 120 before, and they did actually reasonably well too. So there are, so I don't want, we shouldn't write off people just by age, but we should choose according to frailty, and I think that's probably the important thing to do.
Great. Thanks very much for that, Vincent. Actually, comment in the chat about, it is important to be treating the patient. Of course, not, as you said, just it's a guideline. Now, there's been a bunch of questions around the cuffs, so we're going to delve into some of those. The first one is are pharmacy blood pressure cuffs accurate? What are your thoughts on those?
Good question. I think they're better than nothing. So I have patients who, based on their situation, just cannot afford to purchase their own blood pressure cuff. So I will have them go in to pharmacies and do blood pressures there. Now, have they been all validated? No, they have not all been. But I think if you don't have access to it, that's probably better than nothing. If possible, definitely get something that's validated. And important thing being there is that you want comparability between what they're measuring at home and your own machine, which has also been validated, right? So you want reproducibility. So yeah, but I will not write off pharmacy blood pressure cuffs.
And another question just around like some patients, there was a comment, some patients with larger arms sometimes use the wrist cuffs. And any thoughts on those? Are those accurate? Are some of them in that list of approved?
If I'm allowed to be frank, I tell my patients to throw those out. I think we need to stick to what's been well validated and studied, and that's the brachial blood pressures. And I always strongly recommend all my patients to use brachial blood pressure cuffs.
Great. Well, that's clear. In terms of a couple of questions around manual cuffs. So first of all, what is the issue with manual cuffs? And then also, should manual cuffs be used in situations like patients with atrial fibrillation?
Yeah, that's a very good question. So the big thing with manual cuffs, it has been with the reproducibility and technique. So all the hypertension trials, especially the big ones lately, have all been automated, and so we know that reproducibility is present, and we also know that that's what the outcomes have been based on, has been on automated blood pressure cuffs. The problem, I guess, with manual cuff is we can't ensure that the proper technique is used, and we also can't always reproduce a manual blood pressure cuff. The third point is that we've also done studies to compare automated blood pressures versus manual cuff, and manual cuffs can sometimes, manual blood pressure taking can raise the blood pressure reading by about 5 to 10 millimeters mercury as well too. There was actually a very interesting study years ago where they had various people coming into the patient's office to read the blood pressure. So starting with the doctor, then the nurse, then an automated machine. And of course, doctors are the worst. We get the worst, highest manual reading. And then the automated system gets a much nicer looking reading. So we want to stray away from manual possible. Going to the atrial fibrillation, if the automated cuff can't get to it, then yes, you do a manual. And a pointer to the automated cuff is you probably need more than the recommended 3 readings to get a good blood pressure reading in an atrial fibrillation patient. Because of the atrial kick, sometimes you get a systolic carot cough that's a bit higher all of a sudden. So you do want to probably do more readings there, 5 to maybe 7 readings in an atrial fibrillation patient compared to people who have normal sinus rhythm.
Great. Thanks very much for those tips, Vince. Then a couple of questions around diastolic. So why is diastolic blood pressure not considered in the blood pressure target? Yeah, so actually the second question asking the same thing, is there no target for diastolic readings?
Yep. So this is a very big question. And so if you look at the American and the European guidelines, they do include diastolic as something to look at. What we know from the epidemiological and outcomes data is that isolated diastolic blood pressure or hypertension doesn't seem to correlate with outcome as robustly as systolic. And in fact, treatment of isolated diastolic blood pressure also has not been proven to be of effect. And then the third point is sometimes when you have isolated diastolic blood pressure with normal systolic and you treat them, you end up inevitably dropping their systolic and you end up having more side effects than any sort of outcome. Most people with isolated diastolic blood pressure are younger people. They're also people who might have who carry a little bit more weight, and so what we are recommending in Canada in the guidelines is more aggressive lifestyle intervention. Look for those things that you can modify that are not pharmacologic, that don't require pharmacology, and modify them. And treat that as opposed to putting these people on medications, which haven't really panned out to be effective in outcome reduction.
Great, thanks very much, Vince. And then a question regarding hydrochlorothiazide, because yeah, I think a lot of us stopped using it because there was this concern regarding a link to skin cancer. So is that still a concern, or what's your thoughts on that?
No, I think we've been using it for so long, and these association findings are always very complicated. But from in the hypertension world, there is no red flag to continuing use of hydrochlorothiazide. I think there's more. There's going to be way more benefit to proper skin care with sunscreening than any risk associated with the thiazide diuretics in general.
Thanks, Vince. A question regarding sleep apnea. So somebody's wondering how significant of a contribution in millimeters of mercury, if that's possible, is sleep apnea to hypertension?
Yeah. So, okay, whoever asked that question is making me dig back to the days when I was studying for my hypertension specialty. Yeah. So before that, we're going like decades back now. When I first started learning about hypertension, like this was like maybe 2 decades ago, there was a huge push that sleep apnea will always lower systolic blood pressure. Then there came more kind of associated studies about, I think, a decade or so ago, which found that it wasn't as robust of an impact on systolic pressure. But so let's say you had a person who had well controlled blood pressure and they had sleep apnea, and you treat the sleep apnea, you might not notice any significant improvement in their blood pressure. Where the sleep apnea might have a bigger play on systolic blood pressures are the resistant people. So you have a person who's already on triple therapy. You've done all the lifestyle interventions that you think that you can do, and the patient's complying, and yet their pressures are still high. Though that might be a population where you might see a significant reduction in blood pressures with CPAP therapy. We're probably looking, I think, if I'm not mistaken, we're looking at sometimes 5 to 10 millimeters mercury systolic reduction in blood pressure in people who have sleep apnea with resistant hypertension, true resistant hypertension.
Great, thanks very much. So a question regarding the ambulatory blood pressure monitoring, the 24 hours not being covered. And actually, yeah, I'm really interested because both, ambulatory blood pressure monitoring is not covered. And also, we ask patients to buy their own home blood pressure cuffs, and these can be barriers. Any thoughts on that? Is there any advocacy towards getting this to be an OHIP covered option?
Yeah, I ask the same thing too. It really should be covered, and I think we do need to kind of push a little bit more for this because it's very simple. It's not even that expensive of a test nowadays, and a lot of people have them. I'm sure some primary care offices and teams have them as well, but they're not that expensive. So I think it might be something coming, and now that it's in guideline multiple iterations where ABPM is the gold standard
to diagnostics. I think it will be soon that we'll see funding for ABPMs. But yeah, for now, I haven't yet heard much on the horizon that it's going to come for sure. But I think if with a little bit of advocacy, like you said, we probably could make a good case for it.
Great, thanks very much. I'm just gonna pull up the slides and just finish things out before 9, but if you don't mind, we're gonna come back after that just because there are a few more questions that I would love to pose to you. So I'll just turn things over to Eric for the moment.
Thank you. So just putting in a plug for the session. If you've been enjoying these sessions, we are looking for someone to come on board on the planning committee. And this role is remunerated. So if you live outside of the GTA, please consider joining us. So the QR code is on the screen. The slides will be provided afterwards. Next slide. Just some reminders of ongoing and upcoming workshops and educational opportunities from the OCFP. Here's one on children's mental health workshop series, and is coming up on March 9th. So if you're interested, please sign up. Next slide. We continue to offer other communities of practice. Here's one for mental health, addictions, and chronic pain. The next session's on February 25th on insomnia. And if you're somebody who would like to engage to be mentored or to become a mentor for others on topics related to mental health, addictions, chronic pain, you can also sign up on our website. Next slide. We also have small group learning sessions. These go back on. Thank you. And these run from April to March, and these groups meet once a month on a scheduled time. The topics are listed here. If those interest you at all, any of them, please sign up. Again, deadline's coming up March 9th. Next slide. So our 2026 awards program is still accepting nominations. And of course, it is so critical and important that we celebrate the excellent work that family physicians do, as well as potentially future family physicians, our residents and medical students. So if you look around, reflect for a moment, if any of your colleagues and or your learners that you've been in contact with have done some excellent work, please nominate them. Next slide. You may have seen some advertisements in public spaces recently. This is our most recently launched public campaign, really trying to push the envelope about getting patients the care that they need faster. 95% of Ontarians agree that family physicians have access to a centralized referral system, and we are trying to, of course, have our government listen to the needs of family physicians and be able to assist us in reducing administrative burden. And again, you can support this initiative by coming onto our website, sending a letter to your MPP, and also spreading the word by reposting and sharing some of the social media posts that we have ready made for you. Next slide. Okay, and back to you, Dr. Colledge.
Great, thanks, Eric. So just a reminder that we have sessions posted. If you've missed our previous ones, please check them out. And there's one not listed here, but back in the fall, we had one on nutrition, and she did talk about lifestyle and hypertension. So you might want to check that one out. Next slide, please. And just our next session's coming up March 6th. Hope to see you all there. And I think that's the last of our slides. Yes, March 6th, 2026, and everything is posted after our session today, so you can look out for that online. And I'll bring Vince back, Dr. Key. He did mention that he was having to leave his clinic room, so we might have just a second while he's getting back online in terms of finding a phone which he can call in from. So I'm just looking over the questions now. So we'll just take a moment here and hopefully we'll find him back on in just a second. I think, Dan, did you get to all your questions? I believe you did. You answered many.
I think so. There's a
Well
lot in there,
done.
it's hard to track.
Yeah, I know there's a lot at the moment, so it is hard to track. So if you can hang with us, please do, because Vince is now back. Thanks, Vince.
I'm sorry.
No worries. I know you had to move out of your colleague's office, which seems very reasonable. We do all have to run clinics. There's a lot of questions still in the Q&A, so I'm going to give you some rapid fire ones and hope that we can at least get through some of them. And the first couple are specifically around ACEs and ARBs. So the first one is, are there some clinical pearls you have for optimizing blood pressure in patients who are prone to developing hyperkalemia with ACE or ARBs?
Yeah, so that's always a big challenge. So these are the patients you really want to make sure they're on some sort of diuretic, whether it's a thiazide or thiazide-like. If they are diabetic, also a big opportunity for SGLT2 inhibitors to help kind of induce caluresis. Um, we also need to make sure what are the risk factors for hyperkalemia? So diet is a big one. So make sure if they're consumers of high potassium foods to kind of cut back on that. Hydration is also a very big thing for people who are prone to hyperkalemia. This I see more in more elderly patients. They tend to kind of run a little bit more dry, and when you're dry, you're more prone to hyperkalemia anyways. So you want to make sure they're hydrated. Um, Barring that, I do have people who have normal kidney function who are prone to hyperkalemia. And if you've done all of the above and they're still hyperkalemic, if willing, you could consider binder therapy, whether that be sodium polystyrene sulfonate or one of the new binders 2 or 3 times a week. You could consider that. Among my patients who do have CKD, so it's GFRs less than 60, some of them end up being on some dose of those binders 2 or 3 times a week just to kind of keep them out of trouble. And then if that's not something available, then you're unfortunately contraindicated from using that class of therapy.
Thanks, Vince. A question regarding ACEs and ARBs in patients of Black ethnicity because of the risk of angioedema. Any comments around that?
Yeah, so I still don't think the risk of angioedema is like massive in general, in the general population, even in specific races. As long as it's made clear that that there is a risk of angioedema, then you can always trial. I don't think right now we have any sort of genetic testing to prove whether someone is more susceptible or not. But in general, the absolute risk is not massive that we should contraindicate a whole race of patients from ARBs and ACEs.
Thank you for that. So question regarding using ACEs. They used to be considered ahead of ARBs, but of course there's the risk of angioedema and cough with ACE. Should we be starting with ARBs and not using an ACE first?
Yeah, so that came in the whole in during the when the panel was reviewing the guidelines. They looked at all aspects of ACEs and ARBs and combinations of them, and when they looked at kind of the side effect tolerability, and you ranked ACEs versus ARBs, ARBs actually came ahead because they had less side effect profile, namely the cough. Actually, not so much the angioedema. It was more the cough that was more prevalent with the ACEs. And so the recommendation from the guidelines is maybe start with an ARB first for that reason. Yeah, no real cost difference between the two. I don't think you'd be faulted using an ACE upfront either.
Okay, that's good to know. Question around the gout risk with diuretic therapy. Sorry, with diuretic therapy, is there a concern?
You said gout, right?
Yeah.
Yes, so for sure. So thiazide diuretics and even loop diuretics, for that matter, can increase retained uric acid levels. Not everybody who has it will develop gout. We know this from gout literature that not every hyperuricemic develops gout. So there is a patient environment genetic interplay where that increases the risk of gout in hyperuricemics, but we do know uricemia does go up. So it's something to just mention to the patient as a potential risk. Yeah.
And can you add spironolactone without a diuretic? Would you ever do that or?
Yes, you could absolutely do so. Yep. Sometimes they're thiazide intolerant or thiazide resistant, or maybe they do have serious gout issues where you can't, and the spironolactone is not doesn't have as much of the uric acid concern as the thiazide, so you could use it in that circumstance. I actually find, at least my own take on spironolactone, is it is a very powerful add-on therapy. So especially in addition to ACEs and ARBs for optimizing the aldosterone axis. So I don't think there'd be fault to adding spironolactone first, especially if there's an intolerance to a thiazide diuretic.
And thanks for that. On the topic of spironolactone, some concern expressed here regarding the safety of blood pressure and CHF in the real world versus in research trials, because this person has seen a lot of near-miss hyperkalemia cases, people not following Sandmans. Should we be frequently measuring the GFR for patients on spironolactone? How quickly should we stop them if they're ill?
Yeah, and these agents, no, so not just spironolactone, but ACEs and ARBs in general. Even in my own practice with kidney patients, I do every time I do a dose change or a new dose addition or spironolactone addition or dose change, I always make sure I do a 4 week kind of follow up lab test, just to make sure their potassium doesn't go up. You always have to warn patients about the risk of high potassium, especially with the combination of spironolactone and ACE and ARBs. So, and then once they're kind of more stable, I do think, just like blood pressure, we really should be seeing these people every 3 to 6 months, and it's not unreasonable in these people, and especially higher risk patients, to do a creatinine and a potassium. In fact, creatinine is recommended at least annually in all hypertensive patients, anyways. But if we're gonna see patients to follow up blood pressure control every 3 to 6 months, they should have potassium drawn as well too if they're on these agents.
Great, thanks for that. And then a question regarding what are your top lifestyle modifications that you recommend?
And I think you all know my top one is throw those cigarettes out. It is so prevalent of an issue with blood pressure management. So number one, smoking cessation, very aggressive smoking cessation. Keep telling them. I think there's more data that when we annoy our patients, we actually have more success over time than spending a whole session trying to get them to quit in one session. So keep annoying your patients. I think it's completely for their benefit. So number one. Number two is definitely exercise. Sedentary lifestyle for sure is also very prevalent in our population. So I do really encourage people to do physical activity, starting with just simple walks. The recommended duration, I think, is about 150 to 300 minutes per week. So that amounts to about a 30-minute walk, five days maybe per week. So get people to move. I think that's really important. And then weight loss in patients who are carrying excess weight is another big thing as well too.
Great, thanks for that. Some questions regarding the aldosterone-renin ratio test that you mentioned. Is that a simple blood test that can be done at most labs?
All labs can do it. So Life Labs, Gamma, Medcare, all of them can do it. All you have to order in your requisition is aldo-renin ratio, and they'll actually measure out each of them separately, and then the lab will send you a calculated ratio. Best time to do it is morning, so make sure the patients go in the morning, and make sure they're eating a normal diet, they don't fast. You want them to actually maybe have a breakfast before they go, because they need to be on a normal sodium intake. There used to be a call to stop all medications and put everybody on Verapamil and I can't remember, the Trazocin or something like that. And it's just not very medically safe to do so, and easy. And so most of the recommendations now is just do it, even if they're on an ACE or an ARB, but maybe don't do it before they start spironolactone. Yeah.
Okay. And then actually just a question, you had brought it up in the context of secondary hypertension, but there's a question here about should we be checking it on everybody? And I think you've spoken to how they should prepare for the test, but should it be something that we're doing on everyone or only when we're doing a workup?
Yeah, I've heard talks from endocrine enthusiasts, and their message to me is do it on everybody. I think for now, because a lot of these hyperaldos, if they're milder or pre, most of the time we tend to treat first and not necessarily surgical. But of course, the people who are resistant, so you start seeing, oh, they're on triple therapy, compliant, lifestyle in place, but their pressures are not good. For sure, screen, and if it's positive, definitely refer those people. But the easy to control ones, I find it's hard to decide whether it's worthwhile even doing surgery on those ones, because unless they're very young. If they're very young, then maybe there's a good case to try and avoid treatment in general. But a bulk of the patients that you might now start seeing are going to be middle to elderly aged, and surgery might not even be an option there. So I wouldn't say go out right now and screen everybody with an aldo-renin ratio. I would say screen those who are more resistant, and screen those who you do have a suspicion of secondary. So the young people and the sudden onset worsening blood pressure, and of course the hypertensive who is hypokalemic for no reason is a good one to screen.
Great. Now I'm looking at the time. We have 3 minutes. I'm going to try and get you through 5 questions in that time. So we'll see if we can do that. Any concerns about the fact that combination therapies not all of them are covered by ODB?
Oh, I actually didn't know that. So that's news to me. There is no real right or wrong agent to choose. If you put a patient on any one of the combination therapies up front, you're doing an excellent thing. So I would say just get comfortable with one combination. It doesn't have to be the one that the guidelines was using as their example, which is irbesartan hydrochlorothiazide. It could be anything. It could be prindopril indapamide. It could be telmisartan hydrochlorothiazide. It could be any one of the combinations. You're doing a good thing just by choosing any one combination. And if it's ODB covered, all the better for the patient.
Great. And I think actually from that perspective, there's a question, do you max on one BP agent first or add another one? And I think what you're saying is it's always best to have 2.
Yeah. There was that study that I still haven't found out the name in my head, where they actually did people started with single agents, then maxed out, then added on a second agent, then maxed out, compared to a low dose combo start. They found that it was people had much better control at the end of the trial with the combo low dose start, and had less side effects compared to the other arm where they had the max 1 dose and then add a second agent.
Great. And I'm not sure if you can answer this one quickly, but hopefully you can. Where do beta blockers fit into hypertension treatment?
Yeah, if you look at the Canadian guidelines, you're like, where the heck did beta blockers go? And they have actually kind of disappeared. So there is not a very strong recommendation that beta blockers is included in the frontline agents for all comers. The big recommendation for beta blockers is for people who have secondary compelling indications. So compelling indications being coronary artery disease, a compelling indication would be heart failure patients with high blood pressure. those are the people who there's still a recommendation for beta blocker. Now, from a real life experience recommendation, I would say I still have it in there as a potential fourth agent, like with spironolactone. If there is concerns with, let's say, gynecomastia, concerns with hyperkalemia, you wouldn't be faulted to add beta blocker into the regimen after you've exhausted the first line 3. So it's still there. That you can pull on it. You wouldn't be wrong to do so. They just don't have it recommended higher up as a first line, except for compelling indications.
Okay, and last 2 questions. So first of all, just to confirm, the target 130/80 applies to home or office, right? And if a patient has readings at home that are within target, you would take that as legit. And then the last 2 questions are in terms of caffeine, like how much caffeine does someone have to take for it really to be an interferent? Do you have any quick numbers of cups?
I actually don't have I usually say if they drank it just before you did the blood pressure cuff, like within minutes of the blood pressure, probably not a good thing. I don't say don't drink coffee at all, because there are some benefits to coffee as well, but just separate it in time. I think that's the best real life recommendation I give to my patients, unless that's all they drink. So I have patients who come to me with kidney disease, and they only drink coffee and dark tea and no water. And their kidney function is not good. You could kill 2 birds with 1 stone in that case, and get them to drink more water, less coffee, and you might see their blood pressure better and their GFR go up as well too.
Great. I promise this is a very last question. In terms of, are there any ethnic recommendations for blood pressure medication? In the past, there were sometimes.
I think we've strayed away from that now. There used to be more of a recommendation for calcium channel blockers, say in the African Canadian population. Nowadays, I think it's not as strong of an issue now. We know that all agents work in all ethnicities, so the goal really is to get them to control with a combination of any one of the 3 that we've mentioned, and then ultimately they're going to end up being on previously recommended kind of ethnic medications as you described. So they're all going to end up being on it at some point potentially. So for now, I would say choose 2 of the 3 and start from there, and then you'll still be doing good.
Amazing. Well, thank you very much. And sorry, guys, we went to 9:17, so I hope I haven't put people too far behind in their day. Want to thank you very much, Dr. Key, for speaking with us today, as well as Dr. Dan Warshafsky, who had to jump off. And look forward to seeing you all in March, and have a wonderful weekend.
Take care, everybody. Thank you.
Thank you.